podcast. I'm Rachel, a board-certified pediatrician.
And I'm Renda, an OBGYN physician, and I'm also Rachel's mom. So today we're going to talk about GBS or Group Beta Strep. And this is a topic that is near and dear to my heart because my first baby, Rachel, had GBS sepsis after she was born. And it was a terrifying experience for me as a new mom who was really clueless. And it was also the impetus for me to go back to school and study medicine and eventually become a doctor. Now, this was years ago because Rachel is pretty old now.
Hey, wait a minute. I'm not that old, okay? Excuse you.
I know, of course, honey, you're really young. I know. But this was before we routinely tested GBS in all pregnant women. In medicine, we've come a long way since those days.
Yeah, and now GBS is one of the tests that is done during pregnancy, which is nice. It's usually done around 36 weeks routinely for pregnant women. So in this episode, we're going to talk about what exactly GBS is and why it matters. So first of all, GBS stands for Group B Strep, Group B Streptococcus, Group Beta Strep, Group Beta Streptococcus. You can hear it be called all those things.
Right. And GBS is really just a bacteria. It's a bacteria that's commonly found in your GI tract, and also it's commonly found in a woman's vagina. It can sometimes get into the urinary tract and cause urinary tract infections, but usually when we find it in the vagina, it's not an infection. It's just simply a colonization. Okay.
Yeah, because obviously the vagina is not sterile.
Yeah.
There are bacteria living in there, just like there are in your mouth, on your skin. But the bacteria need to be in proper balance to keep it from becoming an infection. And GBS can be one type of bacteria that can just be normal vaginal flora.
Right. So GBS in the vagina usually does not cause any symptoms. It can be a normal finding. It's estimated that 30% of women have GBS in the vagina, and that's normal, not an infection. 30%.
That's a lot. That's a lot.
Yeah.
So chances are fairly high that you could be a carrier for GBS. And because it's asymptomatic, there's really no way for you to even know that you have it.
Right. And Rachel, I know when you were born, you had GBS sepsis and you were really sick and almost died. I also have a very good friend who actually did have a baby die from GBS sepsis. And this was years
Mhm.
ago. It was a healthy, full term baby boy. He got sick right after delivery, had to be transported to another hospital with an NICU. And despite all their efforts, he died. And it's so
That's
sad.
so sad.
So,
Yeah, that's so
yeah,
sad.
GBS is a very scary disease for babies. And so, why don't you tell us a little bit more about that since you're the pediatrician?
Yeah. Yeah. So GBS can be really serious. 80 to 85% of babies with early onset GBS will have bacteremia, and that means an infection in the bloodstream. Bloodstream infections can be very serious and can lead to sepsis. Another 10% will have pneumonia, and 7% will have meningitis. And meningitis is an infection in the fluid around their brain and spinal cord. Symptoms usually appear in the first 24 hours of life is normally what we see for early onset GBS. There is a later onset GBS that can occur later, a couple weeks later, but early onset usually within the first 24 hours of life. And in that time, the baby's going to need IV antibiotics and from anywhere between 10 to 21 days. So they will be in the hospital for a long time getting these antibiotics. And they'll also need
Yeah.
supportive care. So they'll need IV fluids, medications to keep their fevers down, and sometimes blood transfusions for anemia. And, even sometimes they might have to be put on a ventilator to help them breathe. They can also have seizures, and that would also need to be treated. The death rate
Mm.
from a GBS infection is 2 to 3% for full-term infants.
Wow.
That's a pretty high number, 2 to 3
Yeah.
out of every 100 that are born. And that number is even higher for preterm babies. And,
Mm.
some babies can be at risk for developing very serious long-term problems from a GBS infection. Even if they don't pass away from this type of infection, they could have cerebral palsy, seizures, hearing loss, visual impairment, other potentially serious complications. So, in light of all that, the OBGYNs and the pediatricians came together and we weighed the risks and the benefits, and we really decided that screening and treating pregnant women is the best way to prevent this serious illness in newborns. The
Right.
risk to the mom of the antibiotics and treat and screening for them is way lower than it would be for the amount of infants that have serious complications from this.
Right. And that's why we screen all pregnant women now, and it's done at around 36 weeks gestation. So when we find a mom is colonized with GBS, this means that the baby can be infected and get sick within the first few days of life. And that's called vertical transmission, the mother to baby transmission. And it usually occurs when the bacteria from the vagina ascends up into the amniotic fluid sac. And it usually happens after the onset of labor, particularly once the bag of water is broken. So once the bag of water or the membranes, the chorion and the amnion are ruptured, those are what protect the baby from the bacteria that are in the vagina. Normally, the chorion and amnion are a barrier, so the bacteria from the vagina can't get up and around the baby. But once the water is broken, now bacteria from the vagina can get into the amniotic fluid around baby and potentially cause an infection.
Yeah, and GBS is one of the bacteria that can do that. I'll talk a little bit later about all the things that can happen to the baby when the baby is infected with GBS, but I also know that GBS infection can occur even when the membranes are intact and the water hasn't been broken.
Yeah, it can, but that is less common. GBS infection for the baby can also happen as the baby is passing through the vagina on the way out, so to speak. So the baby can pick up the bacteria there in the birth canal. So now we know that giving moms who are carriers for GBS IV penicillin or ampicillin during labor can really help protect the newborn from developing GBS infection.
So in 2010, I know the CDC published guidelines for treatment of moms in labor.
Right. And then ACOG, the American College of Obstetrics and Gynecology, has guidelines for practice. And they recently updated those guidelines just in 2022. So they're pretty up to date.
Yeah, and I know the American Academy of Pediatrics, the AAP, as well as the Nurse Midwife Association also endorse those guidelines. And the key intervention of those guidelines is intrapartum, which means during labor, IV antibiotics for women whose babies are at risk for developing GBS infection.
Right. And it's our job as your OB provider to determine which moms are at risk and should receive those antibiotics. So that's what the testing is all about.
Right. So, I know that all premature babies are at increased risk for infections. So, all babies born before 37 weeks gestation or higher are at risk. Or 37 weeks gestation are at a higher risk. Plus, the immune
Right.
system isn't as strong in premature babies, so they don't mount a
Right.
strong response against infections. So, talk to us a little bit about what are the risk factors that you look for in new moms that would increase their risk of their baby catching GBS.
Right. So some of them are obvious, right? Like if a mom has a fever during labor, right? That's a sign of infection, fever. So if mom's temperature is greater than 100.4 degrees Fahrenheit or 38 degrees Celsius, that means the baby is at increased risk. Also, if a woman's water has been broken for more than 18 hours, that also means that the baby is at higher risk.
Right. Yeah. And us pediatricians, we also look at those things to give the baby a score right after delivery. We talked about it in our inpatient baby care episode,
Right.
if you haven't listened to that one. But after delivery, your baby's provider will give your baby a score. It's called the early onset sepsis score. And in order to get that score, we use mom's highest temp during labor and the number of hours a mom's water was broken prior to delivery, and also if she was GBS positive or not, or if it's unknown. So we use all those things to give your baby a score, and that score determines if we will keep a closer watch on the baby, if we want to check their vitals more often, or even if we need to start antibiotics right away on a baby. So yeah. So what else can put a mom at higher risk?
Yeah, that was really good information. So, obviously, if a mom has had a prior baby born that developed GBS disease, then we would absolutely treat her in all her future pregnancies going forward. Um, we don't need to do the 36-week screen for a mom who's had a prior pregnancy that the baby got GBS sepsis or beta strep disease. She's just automatically going to be treated. So
Like you.
also a mom, yeah, like me. So also a mom who has GBS in her urine during her current pregnancy, we're going to automatically treat them and not do the 36-week test, right? So if anytime during pregnancy a mom has GBS found in her urine, we know she's going to be at risk. Also, all babies born before 37 weeks, Rachel, you just told us that they're at higher risk. So we automatically treat all preterm labor moms because we know those babies are at high risk. They can't fight off the infection as well. And also, if for some reason the test hasn't been done, then we may also recommend treatment. But most of my
We would
patients will be,
recommend treatment as well.
yeah,
The pediatricians, we
yeah,
want you to be treated as well,
yeah.
please, for the sake of
And,
your baby.
yeah. And most of my patients are going to be screened for colonization at 36 weeks. And if they're positive for GBS, then we treat them with antibiotics in labor. If they are negative for GBS, then they don't need antibiotics in labor unless if they develop a fever or prolonged rupture of membranes. There might be other reasons we would consider recommending antibiotics to other patients as well, just based on other risk factors.
Yeah, so I have a couple people who have asked me why we wait until 36 weeks. So, Mom, why do
Yeah,
we wait until
right,
36 weeks? Why not do it
right.
sooner?
Right. So screening is done at 36 to 37 weeks because many women can have a transient or intermittent colonization. So sometimes they can test negative and then test positive later on. Also, we know that any babies born before 37 weeks, we're just automatically going to be treating those babies or those moms anyway. So a GBS swab that's positive early in pregnancy, that may not be predictive of the mom's status later on in pregnancy. We really do want to check closer to term. And also, we said the preterm deliveries are automatically going to be getting those antibiotics anyway. Results from a GBS culture, we think that they're valid for about 5 weeks. So if it's done too early and the mom goes past her due date, then we may get into a situation where the culture really needs to be repeated to be valid. So at 36 weeks, that culture is valid until 41 weeks. And after 41 weeks, we should really retest moms to be accurate.
Yeah. So I know people are going to be wondering who've never had a baby before, how do
Right.
you test? How do you do
Yeah.
this test? I know,
Yeah.
I
And you
especially
know,
know because I just had a baby. And
right,
as a med
right,
student, I used to do them.
right. So
That was
it's
my
really
job to do the
simple.
test.
Oh, really? Well, collecting the
Mhm.
sample is really simple, and we even let patients collect the sample themselves if they want.
I
Of course, your
collected mine
doctor,
myself. That was very
yeah,
nice.
yeah. So your doctor, your midwife, they can all collect the sample. It's typically a swab that looks like a really long Q-tip, and that's placed just inside the vagina in the lower third of the vagina and rubbed around. Then we also rub it down along the perineum. That's the skin between the vagina and the rectum, and then also around the external anus, and then just barely, but just inside the rectum also needs to go because GBS can also be in your GI tract as well. Now, the swab does not need any kind of lubricant, and actually, lubricants like gel can interfere with us getting an accurate result. It's not uncomfortable. Some women find the swabs a little scratchy, but it's really just a Q-tip. And of course, always do the vaginal swab first before the rectal part.
I accidentally did it the other way first, and then I had to ask for a new swab when I did mine. I had to come out and be like, I did my booty first, and I have a new one.
That's funny.
Yeah.
That's really
But
funny.
anyways, I know that then we take the swab, we send it to the lab, and they do a culture and they check for GBS. If you've ever done like microbiology class or grown bacteria, it's kind of where they have one of those petri dishes and they rub the swab on there and then watch stuff grow. So because of that, it can take a couple of days sometimes for the test to come back.
Right.
But we test with every single pregnancy because I know that if a woman is GBS positive in one pregnancy, that doesn't mean she'll have GBS the next time. And so if a woman doesn't have GBS in one pregnancy, she can still have it in future pregnancies.
Right, that's right. Because if a woman is GBS positive in one pregnancy, she still has a 50 to 60% chance of being negative in her next pregnancy. So we test every single time.
Yep. And so treatment wise, the treatment for women who are positive is penicillin or ampicillin in labor. But mom, talk a little bit about what if a mom has a penicillin allergy, then what would you do?
Yeah, that's really important. So if we have a patient who is allergic to penicillin, then we have to note that on the sample that we send to the lab, and the lab can actually then test to see if that particular strain of GBS that that patient has can be treated with a different antibiotic, clindamycin. So they test for the sensitivity to clindamycin, and that's because 20% of beta strep can be resistant to clindamycin. So we don't just automatically use that other antibiotic in patients with a penicillin allergy. We really want the sample to be tested to make sure the clindamycin is going to be effective. And the lab does not automatically do that sensitivity testing. You have to request it. So the way we request it is by noting mom has a penicillin allergy on the requisition form that goes to the lab or in the computer, because now everything's computerized. And then if the bacteria does indeed turn out to be resistant to clindamycin, then we use vancomycin. And that's really the only other alternative that we have. And vancomycin, that's one of our big gun antibiotics. So we save that for
Yeah.
only when we need to use it. Yeah. Yeah.
Yeah. And it can be hard on your kidneys too. So, we try not to use it in people if we don't have to.
Right. Right.
So the GBS culture takes about 48 hours to come back because, like I said, they're growing that bacteria to see what grows. But I know there is a rapid test available where they test for DNA of bacteria. If there is a patient in active labor and you really want to get that result soon, you can order a rapid GBS test. It's more expensive, and most likely some hospitals won't even have that test.
Right. Yeah, right. So, one question that I often get from my patients is there anything they can do to clear GBS before the test is done? There's a push for patients to do more natural remedies. Okay, so I have actually seen patients who put garlic in the vagina to help eliminate GBS before doing the test. Okay, so
Yeah.
garlic is antimicrobial, but this is not recommended because number one, it's not known whether it's effective or whether it's even safe. But there is something that may be helpful in terms of reducing GBS colonization, and that's the use of probiotics. So probiotics can help reduce GBS colonization in an area, and that's an area of growing research and studies. The newer studies that are coming out show that there probably is some benefit to that, but the evidence is just not strong enough yet so that doctors don't routinely recommend it. But I certainly suggest it to patients, especially patients who I feel would be interested. Certain strains of probiotics, like the lactobacillus, has been studied for potential to reduce GBS. And we use lactobacillus for people that get recurrent vaginal yeast infections or recurrent vaginal bacterial infections because it's helpful. Lactobacillus is the normal bacteria, and it can promote a healthy vaginal microbiome, which is what you want. Yeah.
Yeah, probiotics are essentially healthy bacteria that are introduced into the body for their beneficial qualities, and they compete with the bad bacteria. I see probiotics being used a lot to help with gut health, but it can also potentially change vaginal health. And probiotics are generally considered safe during pregnancy. Supplements are not
Right.
necessarily regulated by the FDA, like we talked about before. So if you have to, so you kind of have to do some work to make sure you find a high quality probiotic. Now, I have a question, Mom. Make
Yes.
sure people are very clear cut on this. These probiotics, you are taking them by mouth, correct?
Yes.
You are
Yes.
not putting them in your vagina. Okay.
That's correct. That's correct.
Just want to make
Yes.
sure. I have heard people tell me put some yogurt in your vagina, and it can also do the same thing as the garlic, but
Right.
these
But
probiotics are going by mouth.
no, they're taken by mouth for sure. And yogurt also has a lot of sugar in it. So actually, you're promoting the growth of like yeast and other things that you really don't want in the vagina. So we
Yeah.
don't generally recommend yogurt in the vagina. Okay. So even if you're a
Good.
patient who is using probiotics, we're still going to recommend testing for GBS in pregnancy and treatment if you're positive. If it is positive, we're going to recommend treatment during labor. And we don't retest later to see if it's cleared. So, like if you test positive and then you take a bunch of probiotics and you want to retest, we don't do that. We just treat. So, if you are GBS positive, it also affects how we manage your labor too. Because, for example, if I have a woman who's beta strep negative and her water breaks and the fluid is clear, she may want to just wait a few hours to see if her natural labor kicks in. She may even want to stay home for a few hours. But if I have a woman who's beta strep positive and her water breaks, then I'm going to strongly recommend that she not wait, that she go straight to the hospital, get started on those IV antibiotics, and consider induction or augmentation of her labor, because once the water is broken, the clock is ticking and her infection rate is going to go up the longer you wait.
Yeah. So, if your water breaks and you are GBS positive, you need the antibiotics and you need to get labor started soon. It's important to get the antibiotics in IV form and really in time for them to be effective. And it means
Right.
we want mom to have at least 2 doses of the penicillin or ampicillin 4 hours apart. And really, it matters how close to delivery you had the antibiotics as well. That goes into that scoring for the babies too. So if you have really rapid labor, you'll want to get to the hospital as soon as possible. And if you listen to my birth story, you'll know you don't know if you're going to have rapid labor or
You
not.
don't
So you
know.
better get going.
Right. And if you are in labor, you need to get those IV antibiotics, but you don't have to necessarily stay connected to the IV. It only takes a few minutes for it to run in, and then mom can be up and moving around and walking, taking a shower, bouncing on the birth ball, whatever you want to do to get the labor moving, right?
Yeah. One thing my patients have asked is how the antibiotics in labor can affect the newborn. Can it reduce the diversity of beneficial bacteria in the newborn's gut? And
Right.
the initial colonization of a newborn's gut microbiome can be delayed if the mom gets antibiotics. The infant's gut flora is heavily dependent on that transfer from mom. She is the first person who gives her baby the bacteria that colonize the baby's gut. There is some research that suggests that early life antibiotic exposure could be linked to an increased risk of developing conditions like allergy, asthma, and even obesity. But really, more research is needed to confirm those things. There are some things mom can do to help baby get a good, healthy microbiome. One is that antibiotics should really only be used when necessary and really follow established guidelines to avoid overexposure. It is considered necessary for GBS and preventing
Yes.
GBS transmission. So
Yes.
in the case, so this is the case where antibiotics are appropriate. And like we talked about before, weighing the risks versus the benefits, this could be life-threatening for your baby if you're GBS positive. So
Right.
something life-threatening is definitely appropriate for using antibiotics.
Right.
But you can discuss this with your pediatrician and your OB more. And you can talk to your pediatrician about using probiotics with your baby.
Right.
Probiotics can help restore the balance of baby's microbiome, especially for babies exposed to antibiotics in labor. Probiotics can promote the growth of healthy bacteria. And a lot of my patients use probiotics and say that it works wonders for their baby. So chat with your pediatrician about the use of probiotics. One of the best ways to help get your baby the healthy bacteria is with breastfeeding, whether it's
Perfect.
pumping and feeding express breast milk or feeding baby at the breast. This is one of the best ways to support a baby's healthy gut. Breast milk has beneficial bacteria and also probiotics that promote the growth of beneficial bacteria. So, so
Yeah.
many
Yeah.
ways to help the baby, even if you need antibiotics.
Yeah, that's really helpful. So I want to stress that the testing and the prophylactic antibiotics are really important for preventing early onset GBS disease. You know, since we started using antibiotics during labor in the 1990s, the incidence has really dropped of beta strep disease in newborns. It was 1.8 cases per 1,000 live births, and now it's down to 0.25 cases per 1,000 live births. So there are roughly 4 million births a year. So we reduced the number of babies with GBS disease from 7,000 down to about 1,000 annually. And that's a really big reduction. And early GBS disease, we've already talked about how it can be very serious. So when your doctor recommends antibiotics to you in labor, just know that we do not prescribe antibiotics willy-nilly. We take it serious, and we believe that the benefit of reducing the risk of GBS disease is far greater than any potential risk.
Yeah, I mean, just take the antibiotics. Take it from me, who had GBS sepsis as a baby. You don't want
Yeah.
a sick baby. It's really sad. It's hard on the parents. It's not worth the risk. You wouldn't want to risk your baby's health. So please take the antibiotics if your OBGYN recommends it to you.
Yay. Okay, so I think that just about covers it for this episode. I hope that we have answered all your questions about beta strep, but if you have more questions, feel free to leave us a message. Now, if you are enjoying these podcasts, please leave us a review. We want you to know that we really appreciate you, especially your 5-star ratings. So thanks for that. And yeah, please give us a review and leave us a message if you have questions.
I don't know why my phone did fireworks, but don't forget to subscribe and join us next week for another episode of Mama Doc